Thanks for the invitation for speaking this afternoon. So I'm going to give you an update on good clinical practice for the use of DPD scintigraphy in the diagnosis and management of cardiac amyloidosis. So the two types of amyloid that affect the heart are AL, or light chain amyloidosis, and TTR, or transthyretin, which is a protein produced in the liver. Of TTR, there are two types, wild type and hereditary. Wild-type transthyretin amyloidosis is being increasingly diagnosed, particularly with the advent of imaging modalities such as CMR and DPD scintigraphy. We typically see it in men, and men of a certain age. They may have had carpal tunnel syndrome previously, 5, 10, 15 years before. They may have a pacemaker in situ because they've had an arrhythmia, or they may have atrial fibrillation. So these are sort of red flags that we look for in the cardiology clinic. Hereditary ATTR amyloidosis is less common. Worldwide, V30M is the most prominent variant. In this area, T60A is more prevalent in British Caucasians, particularly of Irish descent, and it shows a mixed picture, mixed phenotype of neuropathy and cardiomyopathy. And increasingly, we're seeing V122I variant, and it's present in around 4% of African Americans, Afro-Caribbeans, so increasingly diagnosing that too. And there's a spectrum. Some patients have more neuropathy, whereas others may have more cardiomyopathy. What's clear, however, is that we're not diagnosing amyloidosis affecting the heart early enough. And this was published a few years ago, led by Theresa Lane, who worked with us at the NAC, and showed that 40% of patients had symptoms for over 4 years before the diagnosis was made. There was a median of 17 hospital attendances prior to the diagnosis and 3 hospital inpatient episodes. So more clearly could be done to make the diagnosis at an earlier stage. So how do we make that diagnosis, and what red flags are we looking for? So this ECG shows a typical appearance where there are small complexes in the inferior leads. And this is what we may see in AL amyloidosis, but actually with TTR amyloidosis, we may see an increased QRS voltage of LVH in around around 50% we see the low voltage in AL, and only 25% of patients with TTR will show the low voltage, and more typically will show the LVH pattern. The echocardiogram can be very helpful in raising that suspicion. So this is a 4-chamber view of the heart. Everything's upside down. We can see that the left ventricle is enlarged, and there's increased wall thickness in the interventricular septum and the lateral wall, but also the right ventricle wall, free wall, is increased. There's this biatrial dilatation, which is otherwise known as an owl's eye appearance, and we can see that there's interatrial thickening and thickening of the valves. Commonly, there can be a rim of pericardial fluid as well. Here are the parasternal long axis view. We can see that there's a large pleural effusion and then that rim of pericardial fluid. On this view, again, the 4-chamber view, I'd like to draw attention to this area where the LV function doesn't look too bad, certainly compared to the basal function. But what we notice is the longitudinal function is virtually gone. And this is what we see typically in cardiac amyloidosis. We can use this knowledge to look at strain. And with longitudinal strain, Professor Whelan talked about that being prognostic in AL amyloidosis, and it's really helpful because it's quite easy to do. It should be part of the routine echocardiogram and doesn't take very much time at all. Essentially, points are taken from around the left ventricle, and those points should all be around -20 of movement within each segment around the left ventricle. And we can see on this side of the screen that this is a normal strain pattern. However, on this side of the screen, a patient with amyloidosis will show this typical bullseye appearance or cherry on top of the cake, because there is apical sparing, so the apical function is preserved, but the basal function is severely reduced. And it's only cardiac amyloidosis that will give this appearance on strain, so very helpful. CMR has also transformed our ability to make the diagnosis in cardiac amyloidosis. In this slide, we can see the amyloid heart along the top and the normal heart along the bottom. We can see that the amyloid heart is thickened in this short axis view looking down through the left ventricle. And we can use T1 mapping as a signal to look for amyloid because of the scar that will be there. We don't need to use contrast for this, so in patients with kidney disease, this can be useful. We do prefer, however, to use contrast and use gadolinium, and we can see that in this amyloid heart there is lots of late gadolinium enhancement in this amyloid heart. Using this information, we can estimate the amyloid burden with the extracellular volume, and as Professor Whelan showed us, we can use that to track either regression or progression of cardiac amyloidosis. But we want to hear more about DPD scintigraphy. I draw your attention to these recent guidelines which have been published on the use of DPD scintigraphy in helping to diagnose cardiac amyloidosis. Who should get a DPD scan? Well, basically anyone that you're suspecting of cardiac amyloidosis. Does a negative grade 0 scan rule out cardiac amyloidosis? The answer, no, because 49% of patients with AL cardiac amyloidosis will have a negative scan. Should a positive DPD scan, grade 1 to 3, be reported as likely TTR? Again, the answer is no, because the patient may have AL amyloidosis, and this needs to be excluded urgently. So this is taken from the guidelines paper. DPD scintigraphy should be considered basically in all of these conditions. I'm not going to read each and every one out, but heart failure in an elderly person or who may also have aortic stenosis. They may be hypotensive when previously they've been hypertensive and they're no longer tolerating their heart failure medication. And I can let you read the rest. But I'm not going to tell you how to grade the DPD scintigraphy. I'm going to ask my colleague, Dr. Quigley, to come and discuss that. Over to you for this part of the talk. Thank you.